event today. We'd like to acknowledge the support of the sponsor of our session, Reckitt Global Hygiene Institute. So to the folks over at RGHI, thank you kindly. Next slide. So our session today is Learning from COVID, approaches to strengthen all of the aspects of the program design cycle. My name is Ron Klemmer, and I serve as the director of the Secretariat for the Global Handwashing Partnership. And we're helping to coordinate today's session as well as Akvo, WaterAid, World Vision, and the Hygiene Hub. Next slide. And today's session is all about the project cycle and how to have the most impactful projects. And that really starts with data collection to inform the design of a project, which is our first presentation. And then we're looking at doing our interventions at scale, but with innovation for the highest impact. Then we're looking at strengthening the monitoring and evaluation process so that, among other things, we can look at how to improve the programming moving forward through that adaptation. After that, we turn to the foundation of projects, which are partnerships and sector coordination. And then we have a treat for you with a learning clinic. But at this time, we're ready to get the show on the road. So Eric, over to you, sir.
Awesome. Thank you, Ron. And good morning, good afternoon, good evening to everyone out there. My name is Eric Siegel. I'm a program manager at Akvo based in San Jose, Costa Rica, alongside my partner, Andres Winograd in Bogota, Colombia. And today we'll be talking about data collection to inform programming within the program cycle, and then honing in specifically on approaches for remote data collection during times of COVID. So we will share 3 experiences of using remote data collection recently in Kenya, Burkina Faso, and Mexico, and then talk about challenges, successes, and recommendations before passing the ball to Dr. Ohm with scaling the approaches up. So let's switch slides, please, and we'll kind of calibrate everyone to onto the next slide, please. So when we talk about the program cycle at Akvo, we refer to the program cycle as the data journey. And that's a 4-phase cyclical methodology. Cyclical meaning it goes in a circle and it's always evolving. So first, in the design phase, during the pandemic, we've been working with partners to gain clarity on the context of their program during the times of COVID-19, which problems they're trying to solve, the data that they need, and the roles and responsibilities of each partner that they work with. This usually involves looking at the entire system, adapting WASH indicators that determine the success of a program to ensure that they include elements of water supply for hand washing, that safety protocols are in place for daily interactions, that hand washing stations, that soap is set up. And this involves programming and for WASH in healthcare facilities, for WASH in schools, for households. An example of the design phase is during the design phase for a national WASH in healthcare facilities assessment, we defined COVID-19 before a national data collection activity happened. We defined COVID-19 related indicators and added questions to the assessment to examine indicators. So this is in the design phase, looking at indicators, then moving to the capture phase where we collect data. We've been, in times of the pandemic, we've been supporting partners to gather reliable and high quality data. Remember, in the design phase, we formalized indicators and created surveys to examine the indicators. And now in the capture phase, we're working with partners to make a data collection plan, to do remote data collection, qualitative, quantitative remote data collection, select and train enumerators, plan for data quality monitoring, and set up a system for technical support in the field. So during the pandemic, focusing on adapting traditional face-to-face data collection activities to remote methods that prioritize maintaining social distance and abiding by the rules of mandatory lockdowns and travel restrictions. So a lot of factors that are new within the capture phase. So we've been moving key informant interviews to Zoom, conducting telephone interviews, using unstructured supplementary service data, which translates into text messaging for surveys, using interactive voice responses and online web forms. So third, we've gone design, capture, now understand, working with partners in the understand phase to clean data, to prepare and conduct analysis, understand information, and then make a plan to use it during the act phase. You see the fourth phase right there is act. So aligning reports supporting partners to align reports with international standards, such as the Joint Monitoring Program, and in preparation for the design phase, for returning to the design phase. Remember, this is cyclical. So reflecting on what we've learned collectively reflecting on what we've learned, designing remote data collection, and seeing if these systems for remote data collection can be used moving forward as we continue to function during times of the pandemic and social distancing and lockdowns and what we are doing today. So next slide, please. Focusing now on, so we have the whole program cycle: design, capture, understand, act. So next slide, honing in on remote data collection to inform COVID-19 response. We've been specifically supporting partners on utilizing technologies. So data collection planning tools, web forms, cell phone applications for remote data collection. And then really, again, the data journey, adapting the whole cycle from data collection, cleaning, analysis, visualization to do remote. And we've also produced some remote data collection guidelines that cover technologies that will circulate here. Andres will share the link to the document that focus on using the appropriate technologies, data collection preparation, planning, team building, incentivizing respondents in the digital world, protocols, training, and reporting. So look out for that document. And here's a quick picture of remote data collection training. The bigger picture is a team of enumerators in Tumaco, Colombia, and me giving a training on how to use the aquagenics bag to test for E. coli presence. And this was all done remotely. Even every aspect of data collection was done remotely. Except many of the aspects were done remotely, except for the actual water quality test that was done in households. So I'll share 3 cases now, very quickly, with the time, about USSD in Kenya, web forms in Burkina Faso, and a last-minute pivot to remote data collection in Mexico. So for focusing on Kenya, together with Kenya Water for Health Organization, QAHO, we created a system for distributing, accessing, and responding to surveys via the radio and text messaging. In partnership with 3 county governments, a local unstructured supplementary service data, that's USSD is the acronym, aggregator called Africa's Talking, and Central FM Kenya Radio. So the system involved Akvo and Africa's Talking jointly producing an application programming interface, an API. This is a system where one digital network can talk to another digital network and pass messages back and forth with each other. So text messaging surveys could be administered. So we partnered with Central FM Kenya Radio to establish a schedule for broadcasting USSD codes so people in remote regions could download the surveys and answer the surveys. And then had QAHO officials in the radio station to interpret the results, the responses that were coming in, and the questions were surrounding effects on COVID-19 pandemic, integrated water management, and gender-based violence. Don't have time to go into the insights, but that link right there is a link to the data library where you can access raw data, clean data, and yeah, interact with the data that is focused on indicators related to gender-based violence and COVID-19 pandemic. Next slide, please. Moving from USSD to web forms. So together with UNICEF, we've been working on collecting data for a COVID-19 response program in 5 regions, 10 provinces, 20 towns, and 40 communities in Burkina Faso. You see the map there highlighted in orange is where we've been working. We have a team in Burkina Faso that manages West Africa's programming. So yeah, we have that. I've got two minutes. So locations were selected by the WASH cluster, multiple country partners involved in the design and implementation. I'll mention some of the priority indicators. Basically, in short, for purposes of time, healthcare facilities, WASH in schools and households, and looking at affecting outcomes. So making sure that in schools and healthcare facilities, staff, patients, teachers are following infection prevention and control measures and using personal protective equipment. 4 types of key informants interviewed, all via phone. WASH focal points, water service managers, NGOs in the field, representatives of displaced populations. There's an internal conflict going, and some very interesting insights related to WASH access, availability, and quality. Internally displaced populations and also host populations, communicating that over 50% said that it was over an hour and a half to go fetch water and come back. And they also do not feel comfortable making that journey because of safety precautions. I'll pass the mic to Andres in 30 seconds. Can you please do a review of the Mexico COVID-19 response? So please, next slide. Andy.
For sure.
Dale.
Thank you, Eric. So long story short, in Mexico, we had to resort to remote data collection to meet our data collection objectives as a last-minute pivot. A sudden outbreak of COVID-19 within the local partner team actually made us change our methodology from fieldwork to remote data collection. And this involved some specific actions that had to be taken. First of all, we set up a call center in the city of Veracruz in Puebla, where we trained the enumerators and conducted data collection from there. We created some joint protocols and guidelines according to WHO, World Health Organization standards, just to make sure we had a safe environment to conduct data collection. We conducted household surveys as phone-based interviews, conducted key informant interviews via Zoom, and we replaced the focus group discussions with open-ended interviews just to make sure we got that qualitative aspect from farmers. So overall, we managed to conduct 63 out of 93 phone-based interviews with a 67% response rate. We conducted all 12 key informant interviews, and we also managed to conduct all 12 open-ended interviews with farmers. Next slide, please.
Awesome. Thank you, Andy.
Yeah,
so go ahead.
Go ahead, Eric. Dale.
No, some, as you can see on the screen, challenges, successes, and recommendations. We absolutely elaborate on all of these, the limitations of remote data collection and successes within the document that's been shared. So please check that document out. Absolutely pay attention to the instrument limitations. Make sure having access to databases is important. Building rapport for enumerators to build rapport with the respondents in a digital world. Trust is an issue always. So making sure taking time to build rapport, working with your local teams to define what rapport means. So you get quality data, keeping gender roles in consideration when designing and implementing. Andres, can you allude to a couple of the successes and recommendations before we alley-oop it to Dr. Ohm to continue? Go ahead, Andy.
Yeah,
successes
Eric,
and recommendations.
If anything, I would like to highlight the issue with representativity, as not all target populations might have access to technology. So when you're conducting your sampling exercise, make sure that the people you are targeting to collect data have access to the technology you choose. Otherwise, your representativity within your study might be hindered. I think that is a key highlight.
Absolutely. And that goes on number one recommendation, understand the context. So it's different geographically and culturally everywhere you go. There's no one size fits all for remote data collection. So yes, work with your local teams and focus on training, incentivizing. Please check the document out. Great to connect with all of you, and thank you for this opportunity. Dr. Ohm, please take it away.
Thank you very much, Eric. Greatly appreciated. Hello, everyone. Good morning, good afternoon, and good evening, wherever you are. My name is Om Prasad Gautam. I'm the Senior West Manager for Hygiene and Behavior Change in WaterAid in UK. Together with me, I have Mobiana, Head of Program WaterAid Zambia, to present our intervention at scale, hygiene response to COVID-19 since last year at scale in multiple countries. Next slide, please. Colleagues, as we are presenting our overall presentation within the framework of the program cycle, as you have seen at the beginning of any hygiene behavior change intervention design, we need to have the insights from the context, from the areas where we want to implement the program. So once you have the insights, what happens? You are then going to design your intervention based on evidence. What I'm going to present throughout my presentation is how have we used the evidence in order to design the intervention, what process we have gone through in order to design intervention at scale and innovatively during the emergency context. So exactly 18 months before, last year, WaterAid responded COVID-19 in 26 countries, primarily focusing on hygiene as first line of defense to COVID-19. At that particular point of time, vaccine wasn't there. Hygiene was the prime preventive measures. We have targeted 99 million population. Initially, the project was designed for 12 months, and this project is still ongoing because of the nature of the virus in few countries. We have targeted in multiple settings, including households, communities, schools, healthcare facilities, public places, and workplace. Hope you can still hear me. We have, in order to design the intervention, we have used a behavior-centered design approach, very simplified version of the behavior-centered design approach. Otherwise, it would have been very difficult for us to get the speed that we wanted. I'm going to highlight that how exactly it was designed. We have focused on multiple behaviors, including hand washing with soap, wearing a mask, maintaining physical distancing, stay at home, and including the COVID-19 symptoms. While designing the intervention, we're looking primary drivers for behavior change, primarily focusing on key motivational drivers. We know that during pandemic like this, the fear is going to be one of the key motivational drivers, but that is going to be quite a stimulus, temporary stimulus at the beginning. Then subsequently, that will create the fatigue, and the people start losing their interest in order to continuously practice the behavior. So therefore, we have used multiple motivational drivers since the beginning of the campaign. I'm going to highlight those. And the desire of this whole program is to make aware about people about the importance of these different behaviors, including hand washing with soap, and make sure that the people actually practice this behavior in order to suppress the virus, while also supporting the sector coordination mechanism. You're using this, the behavior-centered design approach. As you can see, we have used the ABCDE steps, but very light and thorough process. Light in the sense that we didn't have the formative research. We haven't conducted the formative research part of the COVID response, but we did have the formative research findings from the previous work, particularly for hand hygiene component. But then for other behavior, we have done this rapid contextual analysis. We have agreed on the design principle, and then we have identified some of the key motivational drivers apart from the fear, including affiliations, practicing behavior to protect people themselves, their family, nurture practicing behavior to protect the future of the family and the future of the countries, and so forth. Moving from the evidence, then we design hygiene intervention through a creative process. We're already implementing. At that particular point of time, we're already implementing hygiene behaviors and intervention in multiple countries. So we have worked with the government institutions to reactivate the creative process and work with the multidisciplinary team to design the intervention campaign, the intervention assets. Once we have the intervention assets, multiple tools to deliver, we have started delivering it through two different channels. Initially, we focus on mass media, digital and social media because of the nature of the virus, because we really wanted to have a no harm approach. Then subsequently, we have also then implemented through the community-based intervention. So mass media followed it by community-based intervention. And the effect of the intervention was assessed through the midterm evaluation. If we were participating in the first day, the Monday session, the London School of Hygiene and Tropical Medicine actually presented the data from the midterm rapid assessment from our work in 28 countries. So this program was actually designed to implement at scale through innovation. So what exactly happened throughout the pandemic, how we responded, I would like to show you a video in my next slide. Thanks. That's the overall summary of what we have done. Then we have some case examples from the countries where we have curated local innovation. So with that note, I would like to hand over my colleagues, Mobiana. In 2 minutes, would you like to highlight what exactly you have done in Zambia, please?
Thank you. So for Zambia, Zambia is one of the 26 countries where we did the hygiene behavior change, and we called our campaign Kutuba, which just means cleanness. And so we did develop the intervention, and I must say that we already had a running campaign on hygiene, and so we incorporated that the COVID response within our Kutuba campaign. And so we did a light touch behavior-centered design model to just inform where we needed to focus on. And so this followed the creative process that Om was referring to. And within that, we managed to develop packages for mass media and also the communities. And like Om was saying, we focus on the key motives and also identified that one of the key areas where we needed to focus on was to use influencers, and we identified those, and you see in one of the short video that I'll show soon. We also developed some foot-operated handwashing designs, which we use then to influence government to have a buy-in. And like Om was saying, again, we worked in multiple settings to ensure that this was embedded in our programming. On the side of our implementation, we use our influencers to do what we're calling a power of 5, focused on those 5 key behaviors. And we did this through multiple exposures for mass media, more than 10 times in terms of us really ensuring that the behavior-centered design is worked through. And through this, we managed to reach about 7.5 million. Zambia has about 18 million population, so that was quite significant. And we installed in public places some SEM and permanent hand washing stations. So now we've continued with our hygiene behavior change campaign, and I want to show you one of the short videos that is one of the many packages that we have developed as a country. So next, Om.
Let us drive out COVID-19. Wash your hands with soap or sanitize often.
Let us knock out COVID-19.
Okay.
Cover your nose and mouth. Mask up.
Let us win against COVID-19. Call 909 if symptoms develop.
Let us run out COVID-19. Keep your environment clean.
Let us kick out COVID-19. Observe social and physical distancing.
Kutuba, cleanliness is life.
Over to you, Om.
I'm just noting you have 1 more minute left of your presentation.
Thanks. Thanks, Mubiana. So what have we learned from the scale implementation? So 4 key observations, 4 key learnings from the scale implementation. 1, science and evidence-based program design. I think that is quite important. If we design an behavior change intervention in a crisis, we need to know that what are the evidence telling us, what are the sensitive behaviors linked with evidence. Since the beginning of the pandemic, we're focusing on hand hygiene, wearing masks, maintaining physical distancing. And we have evidence that the BCD model can actually be used in a rapid scale, even in the emergencies. And using emotional drivers since the beginning is quite important, and making sure that the design need to be context specific. The second, if we are using mass media, the higher exposure with multiple trusted assets is quite important. Otherwise, it will create a fatigue. And trust is quite important, so that we use influencer, as you can see here the example. And then diversity in the asset is quite important. Diversity in the sense of, like, because you're targeting multiple target population, if you're only focusing on 1, 2 assets, it's not going to be useful for the people to make it context specific. Third, because we have installed hand washing facilities, the inclusive hand washing facilities, it does require a clear operation and maintenance and overtime monitoring aspects. So when you are installing facilities in an emergency settings, you need to have the contract in place, the design in place, and then operation and maintenance plan in place. Otherwise, it would be kind of a big hurdle subsequently to make it regular operational. Finally, focus on inclusivity and sustainability. That's the key thrust. If you really want to use the equity and inclusion, be intentional since the beginning. You cannot just be intentional to use equity at the later front. And particularly for the sustainability, is it important that you use multiple channels, multiple touch points? Therefore, starting from the mass media and subsequently ingrained through the community-based intervention was key for WaterAid to retain some of the outcomes. And while implementing, make sure that we have the content, the package to motivate people, you have the facilities, and all with visual cues and nudges and reminders to reinforce the behavior over time. So with that note, I would like to conclude here. And if you want to know more on our work, I think there are links. Aryan, you might have shared already the links, and you can go there, and you can also touch base with us. Thank you. With that note, I would like to invite our colleagues, San White from London School of Hygiene and Tropical Medicine, for the next session. San, over to you.
Thanks very much, Om. So we're now going to be moving over to around the program cycle to focus on monitoring, evaluation, and adaptation. So it's great to be joining all of you. My name is Sian White, and I'm a research fellow at the London School of Hygiene and Tropical Medicine, and I'm also the response lead for the COVID-19 Hygiene Hub. So for those of you who are perhaps less familiar with our work, the Hygiene Hub was set up in April 2020, and we're a free service to help actors in low and middle income countries rapidly share, design, and adapt evidence-based hygiene interventions to combat COVID-19. And as you can see on this slide here, we've had a range of opportunities to learn from response actors across the pandemic. This is included through technical support, case studies, and through active research with response actors. And we're keen to ensure really that the lessons learned during this pandemic can improve practice in the short term to control COVID-19, but also build resilience against future outbreaks or respond to those outbreaks more effectively in the future. And one particular thing that we've done is to develop learning briefs which synthesize common challenges and identify opportunities to strengthen programming based on insights emerging from practitioners. And so in this section, I'm going to briefly talk through some of the lessons that we've shared in our recent learning brief on monitoring and evaluation. We'll also put this document in the chat. I'd encourage you to read through it as it has a lot more detail and examples from all around the world. So I will share with you sort of 5 emergent lessons around M&E. One of the first things is that we heard a lot during the early stages of the pandemic that really in this acute phase, many response actors simply didn't have time to even think about M&E. And this was really a mixture of being under a lot of pressure to act immediately, but also concerns around kind of doing data collection safely and a lot of unfamiliarity with how to do remote data collection effectively. And also there was a need to kind of measure new behaviors, which was challenging for many. Doing this better in future outbreaks will require us to develop monitoring and evaluation systems that are more responsive to changing circumstances, and of course to invest time and resources and so that we can build skills around M&E to allow people to better adapt in the future. And given that collecting data in the acute stage of the pandemic was so challenging, there are opportunities to make better use of available data. So even though SARS-CoV-2 may have been like a novel pathogen, there are already quite a lot of information out there about how people typically behave during outbreaks, which we could have utilized. In fact, some countries were able to use pre-existing large data sets covering things like water access, healthcare access, and population density. And they combined these data sets to kind of understand areas of vulnerability and high risk to influence their programming. Others chose to kind of work in a coordinated fashion to do data collection, which resulted in maximizing skills and making the most of people's time across organizations. But I think it also kind of contributed to reducing data collection fatigue. And when data was collected collaboratively, it often led to more aligned programming based on that data. So the third lesson was around the value of using a mix of methods. And there are a few reasons why this turned out to be quite sensible during the unpredictability of the pandemic. So firstly, what we saw is that sometimes circumstances change between the baseline and the mid or end line. So it really helped to have kind of an alternative approach for measuring some of our key outcomes. Secondly, the pandemic tended to push people towards using short, standardized quantitative tools. And this was kind of the case irrespective of the research question that they actually wanted to answer. And as a consequence, many actors ended up with data that kind of lacked information that was able to tell them about the why of what communities thought or did about a particular topic. But those who were able to incorporate qualitative methods into their M&E systems were a little bit able to more easily translate findings into programmatic action. During the pandemic, people tended to focus on measuring input or activity level variables, such as the number of hygiene kits distributed or the number of people reached through hygiene promotion, while they struggled a little bit more to find ways of measuring output or outcome or impact variables. And we see this quite commonly during outbreaks. So some actors found that using a theory of change to guide the development of indicators really allowed them to assess whether the programs that they were working on had the impact intended and were implemented in the process intended. It also prompted them to include methods to capture program acceptability and sustainability, and this was something that was commonly overlooked over the course of the pandemic. And our last lesson was around being more strategic about the data that we collect. And this involves making a plan for how each method or question will be analyzed and used in your programming. It also requires making sure that you have the right skills and resources within your team to actually analyze the data in a timely fashion. So I'm going to pause there and hand over to Noor, who's going to take the adaptation part of this stage in the program cycle by giving a case study of Oxfam's work in Lebanon. So over to you, Noor.
Thank you, Sean. Hi, my name is Noor. I'm the Humanitarian Program Coordinator for Oxfam in Lebanon. And I'll briefly talk about some of the programmatic adaptations undertaken by Oxfam in Lebanon as a result of the use of the Community Perception Tracker approach. The Community Perception Tracker approach, or what I'll refer to as CPT, is an approach that allows actors like Oxfam to constantly listen to people. And those people are people who are affected by crises, and adapt and tailor programming according to what those people are telling us. So the programs, the messaging, and the advocacy are updated on a regular basis and adapted to what people are saying. It's an ongoing process that goes hand in hand with programming, whereby field staff are able to collect perceptions of the affected populations. And in the case of Lebanon, this was perceptions from refugee communities on COVID-19. Once the perceptions are collected, those are jointly analyzed and then discussed, and things around COVID-19 prevention, vaccination, lack of information come out as the main perceptions that are shared by people who are affected. It's not a survey, and we do not ask specific questions, but might probe when people mention COVID-19. And this could be while doing distributions or while conducting PDMs, could be through phone calls with communities and community focal points. And it does not have to be through WASH programming specifically. It could also be done through different types of programming, be it protection or cash or emergency food security and vulnerable livelihoods. The process is very simple and uses mobile technology, which allows for real-time adaptation of the program and the shaping and the reshaping of the response and the interventions on regular basis, and in direct response to simply what people are saying about COVID-19. Next slide, please. One of the examples of the use of the CPT for program adaptation that stands out is what we were able to achieve at Oxfam in Lebanon with the COVID-19 vaccine promotion. Through listening to refugee communities and through the early detection and tracking of concerns around the vaccine, we were able to adapt the program to suit the needs of people and fill information gaps in a fairly quick manner. As you see on the left-hand side of your screen, the CPT allows for the visualization of perceptions and trends, in this case on the COVID-19 vaccines. From January to April 2021, people had more questions about the vaccines and less access to information at a time when vaccination was still a very new topic in Lebanon. While not planned, and in response to perceptions collected, we rolled out a vaccine promotion plan. And this plan was improved through listening to people and through adapting and tailoring the program in response to what people were saying. So it's not the other way around. It's actually people who designed this intervention. What's very interesting is the fact that it actually all started with one perception. One perception got us moving. We did not need to wait for results or findings. We were directly able to respond, as it did provide real-time information from people on their perceptions and their thoughts and their concerns. We were able to reallocate some of the funding available in country to fill in gaps, but we also asked for additional funding to support the process. The development of information material, of all information material shared onwards, became geared towards addressing concerns raised through the CPT. We were able to identify people from within the communities who became trusted sources of information and channeled the vaccine promotion through them. And then we were able also to deploy staff and work with local actors to support people register on the government registration platform for COVAX, which was identified as inaccessible at first through the CPT. As we went on with the promotion and the CPT, concerns around accessibility to the vaccine centers were also surging. And in response, Oxfam offered to facilitate access through covering transportation costs to the vaccination centers. While some issues remain unresolved and some issues will remain unresolved for the affected populations, we were able to raise their voices and concerns that were relayed to us through the CPT. There is one success that I'd like to mention here, and it's through making mobile vaccination available. The CPT identified that as an issue, and we were able to make mobile vaccination available, especially for people living with disabilities, through specialized actors, through advocating with specialized actors who were able to provide such services. Overall, the result was an increase in registration on the government platform for vaccination and a reduction in concerns and gap in information on the vaccine. This continues to be a priority for Oxfam in Lebanon, even amidst the multiple crises we're facing. And we have for sure learned a lot through listening to people and adopting different yet efficient approaches to responding to people's needs. And now I'll hand over to James.
Can everyone see those slides again?
Yes, we can see them.
Opportunity. I'm here to share something, work we are doing with Convening Foundation and other partners. The focus is on partnership and sector coordination at the district level. Can we, next slide, please? Yes, there are 260 metropolitan and municipal and district assemblies in Ghana, of which my district is one of them. The MMDAs draw their functions from Section 12 and Section 13 of the Local Government Act, that is Act 936. They perform a variety of functions, including both deliberative, legislative, and executive functions. They are tasked to also coordinate, integrate, and then harmonize the execution of programs of all development partners and public organizations working within the jurisdiction of the Assembly to bring them together to provide development to the doorstep of the people. It is on this premise that the Assembly, in collaboration with Convening Foundations, guarantees. That is, we have IRC Ghana, Acquire Institute, Nexcentric Campaigns, Safe Water Network, Center for Disease Control and Prevention, World Vision International. We have and other stakeholders under the initiative, auspices of the Handwash initiative. The Handwash stands for Asutifi North and Puntu initiative. We have been working together to implement a long-term wash master plan, provide sustainable universal access to wash services for the people in the Asutifi North since 2017. Over the period, we have been able, 11,500 people have experienced some level of water service improvement, which safely managed, increasing from 5% in 2017 to 15% in 2020. Basic water supply also increased from 52% in 2017 to 61% in 2020, while the unsafe it was that time that we had the COVID-19. So can we go back? We had the COVID-19. In response to the significant threats posed by the COVID-19 in 2020, the Asutifi North District Assembly, working with the ANAM partnership, prepared what we call epidemic preparedness and response master plan to combat the pandemic at the district level. It is the ANAM framework that we're working on that formed the basis to prepare that decision. This was prepared in line with the national broad objectives. This coordinated plan ensured the mobilization of resources from all partners and stakeholders, including a grant of $100,000 from the Convening Foundation to address immediate COVID-19 and early preparedness and medium-term resilience efforts. And we're also to mobilize additional $20,000 from Newman Ghana, that is a Newman Gold Corps Ghana Limited, to implement IPC intervention in healthcare facilities and public institutions. Here, if we look at the whole lesson we are doing, the case is how we are deepening partnership and coordinating through political leadership in the Asutifi North District. You realize from the work that we are doing is that with a strong political leadership in the district inspired and increased the trust and confidence of all stakeholders and partners under the ANAM initiative that brought about the needed support that we need. The unique expertise of each of the local government stakeholders. Here we are referring to the Ghana Health Service, the Ghana Education Service, the Ghana Police, and then the Agri Development Unit, and our partners. Here, the partners include IRC, World Vision, Save Water, and Eccentric Acquire, and Newman. We all played a key role in the operationalization of the WASH Master Plan. So to oversee the implementation of the plan, after we prepare the disaster preparedness, epidemic preparedness, and emergency plan, to oversee the implementation of the plan, a public health emergency committee with members drawing from the various stakeholders and partners was set up. Through the work of the committee, health personnel, community-based surveillance volunteers, media, the over-the-counter medicine sellers were all trained. And others were all trained on what service delivery to combat the COVID-19. Also, there was a donation of PPEs and other hand hygiene supplies, while isolation center was also created with water extended to these areas. This was done under the coordinated program. We're able to liaise with our partners to provide isolation centers and then other PPEs to combat the deadly. We leveraging on each other's strength to combat the COVID-19 was something that we draw from the partnership. We're able, one of our partner in Eccentric campaigns gave us the opportunity to use part of his lesson to design and also share on, do a lot of sensitizations on what we are doing. Collectively, we came together to design campaign messages to be on the various radio stations and community information centers to spread about how we can combat the disease. The committee effectively coordinated the mobilization of both human and logistical financial resources for the preparedness plan. So like I indicated earlier, a total of $120,000 was mobilized, and Newman donating a pickup for the COVID-19 response team, any activities related. So we use this pickup to go around to sensitize the people on what we are doing and what. On next slide. 5 key lessons that we would like to share on is, if you look at the whole thing, you cannot, in this era, you need partnership. You alone cannot do it. And to be able to do, you need that political and financial commitment from both the assembly and from your partners. If there's a will, there will be a way. If you are not committed to the whole initiative, addressing or tackling the COVID-19 pandemic would be a challenge. So lesson one is we realize that there is that political and financial commitment from the district and our partners, who there's also that high level of interest and financial support from our partners. If you look at the stakeholders, the partnership we are working within, we have diverse stakeholders who are committed with all common goal, working together to ensure that we achieve a common vision. If you look at the partnership we are having at the local level, the assembly provides the political and leadership to ensure to drive and coordinate the partnership. World Vision for
I think James may have unfortunately got disconnected there. Hopefully he'll be able to return, but we are drawing to the end of our session anyway. And so we now encourage you to post any questions in the chat if you are able to. And then I will hand over to Aaron, who's going to start us off with the discussion.
Great, thanks, Sean. Yeah, hopefully we can get James back on. But for now, I think we can just continue to move forward, because I do want to dive a little bit deeper into these different components of the program cycle. And it's great to hear all these presentations and especially hearing those lessons learned. But of course, we do also want to hear from all of you. And so again, I invite you to share your experiences through the Pathable chat, or if you raise your hand, we can also unmute you as well. And so while we wait for some of those insights to come in, whether through the chat or through raised hands, Eric and Andres, I'd like to just follow up on your presentation quickly. What were some of the most challenging aspects of collecting data during the pandemic and then transitioning this into programmatic activities?
Ante, you want to go ahead and talk maybe about, from the Mexico perspective, about accessing databases, the sampling challenges maybe, and then we can go from there. We can talk, if you don't mind.
Yeah, for sure. I think at the beginning of the pandemic, we weren't really planning around remote data collection. So adapting our data collection plans to the remote version of them was a challenge, because we encountered issues like Eric mentioned, for example, access to technology, specifically in farmer populations or in populations that might not have access to telephones, smartphones, tablets, etc. It was hard to get a hold of them. And one of the barriers was also having a reliable database. So really working with partners in advance in order to get that information before, I think is crucial. And then being able to translate the data you collect with those limitations into reliable reports. So taking into account representativity was something that we encountered and that we advise people to look into for their data collection efforts.
Yeah,
thank you, Andy. And also the feedback loops. So especially with that last minute pivot, it was like, how do we get the beneficiaries of a program, the farmers that are accessing the inputs, in this specific case, the respondents to the USSD in Kenya, how do we get those in? You know, we had the health officials at the radio broadcasting the insights, but yeah, how do we create a portal either digitally or through local community systems to disperse the information so data is able to be used? As Sean alluded to as well, making sure that data is used. So thinking about the whole program cycle from the design phase to the act phase, how can we ensure that the data we're collecting is going to be useful information for making decisions?
Yeah, definitely. That's a great point, Eric.
If I may jump in there as well, Aaron, like I think one really nice example I saw was in a partnership that the Hygiene Hub did with Save the Children in Syria. And what we actually did is take their kind of standardized templates that they were thinking of using, standardized surveys. And we went through each question and we said, why are we asking this? What information do we think we'll get here and how are we going to analyze it? And kind of breaking down any methods to that level of detail before you roll it out in communities can actually be really useful in making sure we're not collecting unnecessary data.
Yeah, definitely. Yeah, I mean, I think it's great too. And again, it's important that we link the different elements of the program cycle and seeing how it all connects together. I'm just trying to check the chat to see if there's any insights that have been added, but and Mubiana, could you maybe discuss, what was the most challenging aspect of, programming at scale? What was the most challenging aspect of designing or delivering COVID-19 response programs for WaterAid?
Thanks, Aryan. I think that the biggest
challenge. Yes, thank you so much. So,
Mubiana, you want to go ahead first? Go ahead.
Okay. Okay. You wanted to go first?
You go ahead, Mubiana, please.
Okay. So I think the initial aspects of us responding to something that was completely new and incorporating it with, so to speak, limited information, but also required to move at scale to ensure that we're keeping abreast with what was happening. It's something that really was challenging, but also the shift in terms of attitudinal aspects. So I would basically talk about 3 levels. One is at some sort of policies framework. Secondly is at institutional framework. And thirdly is at attitudinal level. So you have to attend to all these to ensure that if you're working with the government, they put in place frameworks that really support those changes that will be able to absorb that. The structures or institutions that are in place also need to be adapted to be able to respond to that, as well as both the staff and all stakeholders in terms of attitudinal changes that need to be put in place, and also the general community. So I think in a nutshell, I'll summarize it as such.
Thank you. The 2 challenges, very quickly, 2 challenges on the design, the lack of real-time data at the beginning, because therefore WaterAid needed to invest a lot on the conducting the midterm rapid assessment to make our ongoing program progressive. The second, because of the nature of the virus, people need to know the behavior they need to practice. Then we need to move, making it trusted assets. And then trusted wasn't enough. Then we need to make it more emotional content in order to change the behavior. Throughout the pandemic, because of the lockdown and so forth, the creative process to make these consistently progressive asset was quite challenging for WaterAid. That's 2 on the design. 2 on the delivery. I mean, as much as we wanted kind of deliver at a scale, what happened, because we needed innovation, because a ritual hand washing station is not going to work. At the beginning, it was kind of droplet infections. Everybody wants to see, or regular hand washing station is not going to work. We need to have a foot operated to reduce the cross contamination and so forth. How do you come up with the design in an efficient way that will reduce the level of contamination across people? That was one challenge. Local innovation. There are lots of innovations happen, but we had to put lots of effort on it. Third, as much as we wanted to have the innovation, the mass media focused intervention delivery was completely new. And then we were unsure at the beginning that how much effect it will have to the wider audience. It was good in terms of reach, but whether or not that will translate into the behavior change is what quite a challenge. So therefore, mass media followed it by community events. When you go to the community, of course, there are lots of implications in terms of group gatherings, the maintaining physical distancing, because the environment was not fit for purpose throughout the pandemic. So kind of that lack of kind of feasible environment to deliver the robust behavior change intervention campaign was itself one of the challenges throughout the pandemic. the POCI. Thanks.
Yeah, no, that's great. Thank you so much, both. And Noor, a question came in for you in the chat. For the community perception tracker, how are these perceptions captured without a survey? Could you briefly describe the technical process?
Yes. So anything, any field staff, any Oxfam staff, any partner staff is doing at any given moment, distributing hygiene kits, water trucking monitoring, water quality monitoring, anything that's taking place now. Someone comes to you and says, I think COVID-19 does not exist. And then you, what you do at that moment is you just ask for their consent to record what they said and record it on a tablet that's usually with the field staff or with the partner staff that are discussing or providing the service at the time. And they might probe a bit to understand better does not exist, or why they believe that COVID-19 does not exist. And this is how we basically collect those perceptions. So no active questioning of through surveys, and no set or structured questions in place.
Great, thanks, Noor. Yeah, so I know we're just about time, and I know that there's still quite a lot of questions, so hopefully we can continue the discussions in the chat. Thanks, Sean, for sharing the slides on the screen here. But again, it's great to hear your experiences and how you've adapted your program for COVID-19 response. I just want to close this session by discussing opportunities to continue learning and sharing. We've included a couple of different links and suggestions on the slide here, and perhaps we can link some other pertinent resources in the chat after this as well. But just to go through the ones on the screen a bit more, the COVID-19 Hygiene Hub is a really great resource for technical assistance for the pandemic, and over the next coming weeks, the website will evolve to become a long-term repository of resources, learning briefs, case studies, and so on, that you can really access to inform your COVID-19 response and other disease prevention programs in the future. And then, of course, as a representative of the Global Handwashing Partnership, I have to plug some of our resources as well. We have a comprehensive hub of resources for hand hygiene programming, and we recently launched the Handwashing Handbook, which is an all-in-one resource for hand hygiene champions, and that's available on our website as well. So I highly encourage you to check both of those websites out. But the important takeaway from this session is really that the pandemic has been such a unique opportunity to adapt our programs and to really strengthen our approaches throughout the program cycle. We heard a lot of great examples from our presenters today, and hope to continue those discussions in the chat. So really, to end this session, I encourage you to not end the discussions beyond UNC, and take this to your day jobs as well. We want to ensure we continue to learn and share so that we can leverage this knowledge and apply best practices for future outbreaks. And then if we could just end on that closing slide, please. So just to close, I want to thank our session sponsor, the Reckitt Global Hygiene Institute. Once again, they're certainly part of this conversation moving forward. And again, thank you to all of our speakers and to you all for joining us today. Please do continue to use that chat on Pathable, and we look forward to continuing sharing our lessons learned. Thanks, everyone.
Thank you, Erin. Thank you, everyone.
Thank you.
Thank you.
Bye-bye.
Bye.